let's begin with an acknowledgement of country, and I would like to acknowledge the country on which I work and live, which is Wurundjeri country, and pay my respects to elders past, present and emerging from those countries. I also like to pay my respect on your behalf of all the different lands on which you are perhaps today or normally working or living. And if you would like to put your country in the chat, please do so. Please feel free to do that. So today, Utsana and I would like to share on behalf of a much bigger team the outcomes of a randomised controlled trial, so a study that we have been doing for the last several years to investigate the effectiveness and the cost effectiveness of providing a wrist-hand orthosis, which are also called splints, for children with cerebral palsy. So, as I've said, my name's Christine Imms. I have an occupational therapy background and I currently hold the role of APEX Australia Chair of Neurodevelopment and Disability, and I'm a Director of a research, Child and Youth Disability Research Hub on the University of Melbourne and the Royal Children's Hospital campus. Watsana, I'll throw to you to introduce yourself.
Yeah, hi everyone. I met some of you in different occasions, but many of you I haven't met. So I'm Utsana, I'm a PhD student and also a research fellow at Deakin Health Economics. I help Christine and her team assessing the cost and also another outcome from the health economics perspective that I'm going to talk about today.
Thanks, Utsana. So our plan for this, we're going to talk for about, we hope about 20 minutes, 20 to 25 minutes, and you can stop us talking when you're tired of us. So what we'd like to talk about today is why we did this study, how we did the study, what we found out about the orthoses, and what we found out about the costs, and then I think try to pull it together into what we learned overall and tell you about what's happening next. So that's our plan, and we'll just jump straight into it. So I guess the first part of that topic is, why did we do this particular study? And I love this photo of a young man who has CP. He's a DJ. That's what he loves to do and does so beautifully. And really the reason why we do all of our research in the area of CP and disability is really to understand how best to support young people to grow up and do the things that they're passionate about. But let's go back to this particular study, and I think to set the scene for this orthosis study is that we know that children and young people with cerebral palsy have problems with movement. That's part of the definition of cerebral palsy, and that's commonly associated with spasticity, or that sort of tenseness in the muscles, and that places them at risk of getting stiffness in the muscles. And particularly in this study, we were focused on what's happening in the muscles and joints and soft tissue of the wrist and hand. And the stiffness that can happen in those muscles can lead to a loss of movement and shortening of the muscles, known as contracture. And some of those changes that happen can affect the way the hand looks, but also, more importantly, how hands can be used. And it can make it hard for children to use their hands in their daily activities, such as eating, dressing themselves, managing toys or manipulating objects. Can also make it quite hard for people who are providing support for daily care, for those young people who actually don't use their hands themselves to look after themselves, but need support to do that. And so we're really interested in what can we do, what are all the things that we can do to help maintain range of movement in the hands and arms to really support active use of hands, but also, even when there's not going to be active use, actually support good pain-free range of movement in that hand as best we can. So in terms of young people with CP, who does this sort of potential loss of range of movement and stiffness happen to? Well, we don't have a lot of research about this, but we do know that from one Swedish study of about 770 children with CP, they were able to follow young children across time and able to show that about 1 in 3, 34% of children would develop a contracture in their arm, and of those, about 1 in 5, or not of those, altogether, about 20% of the children would get a contracture at their wrist. And so the picture that I have shown you there shows you what that looks like when it's really quite significant contracture. So a lot of loss of range of movement. That hand is not very usable in terms of being able to manipulate objects or to hold things. So that wrist position there is what we're seeing in about 1 in 5 something like that, or degrees towards that, in about 1 in 5 young people. So how do we treat things like this? So what we know is that orthoses, and I'm going to use the word orthosis and splint interchangeably in this presentation, just because that's different language that people tend to use. So we do know that traditionally therapists have been providing children with cerebral palsy wrist-hand orthoses or splints to wear at night to stretch the hand and to prevent that muscle stiffness and loss of movement. So as therapists, we think that that stretch reduces the stiffness and tightness that those muscles experience during the day. And even though orthoses are commonly given to children, there's no research that shows if they're effective over the short or longer term, so from 1 to 3 years. And we also don't know if some children with CP are more likely to benefit from wearing an orthosis than other children. And so this was, we kind of had this common practice, bit of dissent about whether it works, and we really needed to do a study to really try and answer that question. We really hoped to answer it very firmly. We were hoping to get the answer was our goal. Okay, so what we wanted to know was if wearing that wrist-hand orthosis overnight for at least 6 hours overnight or during a resting period and for 3 years, whether or not we would see that there was an improvement or a prevention of that loss of range of movement at the wrist, if there was a reduction in that muscle stiffness and pain that can be associated with that stiffness and change in hand position, if young people could use their hands for their daily activities, or indeed caregivers could provide care more easily, and also if there was any improvement in participation or quality of life. We actually had also aimed to look and see whether or not it mattered if you started providing the intervention at a younger age rather than an older age, or if it mattered if you had a more or less severe form of spasticity in your hands. That's what we planned to do. We actually had also planned to run the study for 3 years to really understand that long-term outcome, because what we know is that children grow, and as they grow, they change. And often the studies that had happened before this particular study was planned were really short-term. They're really looking to see if those orthoses or splints would make a difference in a very short period of time, and they weren't really showing us that they weren't. But we know that in practice for children with CP, if we were going to provide an orthosis for the hand, we were going to provide it for a long period of time. So that's why we wanted to do a longer-term study. So that's the why. So how do we go about it? So the first thing to tell you about is the study design. And so first of all, what we did was we partnered with people across the country. So we knew that we needed to do this study well. We would need a lot of children and young people with CP to come into the study, because if we were going to answer that question really clearly, we would need to recruit a large number of children to be able to understand both what happens over time, but also if age matters, if severity matters. So we needed quite a large number of children. So we partnered with the 3 biggest, most populous states of Australia, so Victoria, New South Wales and Western Australia, to do this study. The next thing we did was we worked out how many children we might need to recruit to actually answer our research questions definitively. And we worked out that we would need to recruit 194 children or teenagers to be able to collect the information that we needed. And we're really looking for the smallest, most useful difference from wearing that orthosis. And we can talk about those details if you have questions about that. But that was our goal. We aim to recruit young people aged 5 to 15 years, knowing that by age 5, according to the literature that we have, that some young people would already have some changes in their muscle stiffness. They might have started to lose range. So we're really interested to see whether, if that's the case, does an orthosis help it from getting any worse, or in fact, can we go back into the right direction and increase range of movement? And this was a study for young people who had cerebral palsy and spasticity in their hands. They might also have other movement problems like a dystonia, but they needed to have spasticity. If they didn't have spasticity, then this was not the study for them. And then the last piece of the design that I want to focus on is that this was a randomised controlled trial. And by that, what we mean is for those 194 children that were recruited to the study, who came into the study, we were going to essentially flip a coin to say whether or not they got the orthosis or they didn't get the orthosis. And so the reason that was really important, because the reason for doing that is to make sure as much as we can that our two groups, the group who do get the orthosis and the group that don't get the orthosis, are pretty much alike to each other to start with, so that if we do see a difference in outcomes over the 3 years, that we think it's because of the orthosis, not because of something else. Okay, so what we ask the children and families to do, so the first thing to tell you is that for the young people in the orthosis group, we asked, they were provided with an orthosis, so a splint, to keep their wrist and fingers in a stretched position. So the picture shows you something like what that orthosis looked like, and we asked them to wear it when resting or sleeping, not when they were trying to use their hands, for at least 6 hours. And we prefer that to be overnight when young people are sleeping, but for some young people it could be in the day if they were not otherwise using their hands. So all the orthoses were made using the same instructions that our study team put together. So we had a sort of a standard set of instructions for whoever was making the orthoses. And the children in the orthosis group, or their parents or guardians, were asked to keep a diary. And we used a therapy app for that. A diary of how many hours they actually spent wearing the orthosis each night, and if the orthosis caused them any problems. And then that actually sent them a prompt every day to do that, or was supposed to send them a prompt every day to tell us about that. And then once a week they were also asked, what therapy did you do? What other treatments did you get for your hand this week? They were also asked to attend assessments every 6 months so we could track what was happening over time, and to keep on doing everything else that they would otherwise do according to their team. Children in the control group were asked not to wear an orthosis, so if they had an orthosis already, they were asked to stop wearing it. They were asked to keep the diary about interventions, to come to the assessments and keep doing their usual therapy. So what did we measure? What did we want to know? What could change? We were really, first of all, we wanted to know who came into our study, so we knew who we wanted, and then we wanted to know actually who did arrive in terms of how old they were, the type and severity of their CP. And then our main outcome was wrist extension with fingers extended, and that's the picture that I've shown you in there. And the reason for focusing on that as the main outcome is because that's what the orthosis is supposed to do, is it's supposed to change or maintain range of movement. And then all the other benefits from having good range of movement come after that. And so that was why that was our primary outcome. So the assessments were completed every 6 months for this particular assessment for 3 years or until the study ended. And they were done by therapists who didn't know whether the child was in the orthosis group or not, so that they couldn't be biased by that. They were trained to make sure that they did their assessments as accurately as possible. So we did this, we collected this information passively, so that means the person who was collecting the information moved the wrist into that position. We also collected a lot of other measures. We wanted to know things about hand and arm function, so we wanted to know generally about movement. We wanted to know about pain and stiffness. We wanted to know about activity, so really were children able to do anything more with their hands in terms of their everyday tasks. We wanted to know about participation in home, school and community. And we wanted to know about quality of life, both of the children and the parents, and we're going to come back to that with Utsana's part of the presentation. We wanted to know how much it cost to undertake healthcare if you had a young person with CP, healthcare visits, the pharmaceuticals that you used, any surgery or hospitalisations, and we wanted to know what other therapies young people received. Just watching the time and going to speed up a little bit. So the other important thing for us to know is that we had to stop the study early. We ran out of time and money because it took us much, much longer to recruit people into the study than we had originally planned. And on average, even though we wanted to have 194 children in the study, we could only get 74, and we couldn't follow them for 3 years. We had to stop. On average, we kept people for about 18 months in the study. So you need to hold that as we talk about the findings. So what did we find out about the orthoses? So first of all, let me tell you who did come into the study. So I've already told you that there were 74 children who came into the study. Their average age was about 10 years, 9 to 10 years in both groups. There's just over half of them were girls. And most of them had a manual ability classification level of 1 or 2, which meant they were predominantly using their hands with some difficulty, but were using their hands to do some activities. But we did have young people across all max levels. We also had young people across all levels of the GMFCS, so their gross motor function levels as well. So we need, importantly in this is that to show you also that there were no systematic differences between the two groups. So we know that the children in the control group were somewhat alike to the children in the treatment group, in the orthosis group. So the big question, did the orthoses increase range of movement? And at the end of the study, knowing that we stopped early, we would say that we found that children in the orthosis group had an increased range of movement on average of about 13 degrees more passive range of movement in the wrist with fingers extended at the 6-month assessment than the children in the control group. And at the 12-month assessment, they had about 21 degrees more wrist extension. So we had sort of a slowly increasing amount of difference between the two groups. But some children had a lot of change, some children had no change, and some children got worse. Okay, so it's important to know that there was variability. But there were not enough children in the study after 18 months for us to tell you anything more than that. So we could not get an answer for the 3 years. What else we learned was that that in terms of hand function, we had a small inkling that there might be an improvement in grip strength at about 12 months for some young people, but nothing more. There were no other changes on hand function, ability to do activities, or on participation. Were they worn? So we can tell you, and we can talk about this for a long time, but I'm just going to give you the high-level summary. The children who got the orthosis reported wearing it about 28% of the time. So about 1 in 4 days for an average of about 7.5 hours. So when they were wearing them at this age, they could keep them on for that time, but they were only wearing them about 1 in 4 days. We also need to know that actually there were side effects, and so that young people commonly reported, about 70% of young people with an orthosis reported that there was some skin irritation or redness or trouble sleeping associated with getting the orthosis, but those problems tended to be very short-lived. They tended to only last about a week. So I'm going to stop. So that's what we learned about the orthosis. I'm going to hand to you, Roxana.
Thank you, Christine. So I have 3 slides that I'm going to confuse you. Hopefully it's not. So we're going to talk about the cost to begin with. With the cost, as you can see that the orthosis group spent less on the healthcare compared to the control. And even we add the orthosis cost in as a 370, and that is the cost derived from the NDIS as a reference price. The orthosis still spent less than the control group, but that is the on average one. There are some variabilities as well that we can spot. If you're looking at the right-hand side dots, and the vertical red line is when there is no difference between the costs between the two groups. So if the dots line above, it means the orthosis spent more. If it lines below the red line, the orthosis spent less. It's more like tossing a coin. There is the 50-50% chance that the orthosis can save or not saving the cost. Next slide, please. Then we're looking at the quality of life outcome, because as Christine set the scene that from getting more range of movement, that would be at ease of the care, right? And also have the quality of life impact on both the child themselves and also their parents as well. And what we found is there's not much difference between the two groups, especially in terms of the quality of life of the children themselves. Over the period of the study, on average, the quality of life of the child was about similar in both groups. Well, this one might not be familiar with so many of you, because the scale that we measure the quality of life ranged from 0 to 1. So whatever line towards the 1 end is good, because 1 represents full health, a very healthy one. The 0 represents dead. And what does it mean about the 0.77? Well, I look at the general quality of life of Australian kids. The average is about 0.78. So they are pretty much in line with other kids without cerebral palsy. And again, this is the average, give you pretty much the same. When we look closely on the below green dot lines, you can see the difference between the children's quality of life between the orthosis and also the control. So the vertical red line is more like a reference line again. If the dots lines on the right-hand side, it means that the orthosis group has better quality of life. It's another way around if the dots line on the left-hand side of the red vertical line. We can't really tell for certain because there are chances that the orthosis can improve quality of life, and there is also chances that they don't. The quality of life of the parents are quite interesting. What we found and what we expect, supposed to be more quality of life in the parents in the orthosis group because they gain more range of movements and also can do more using their hand. But what we found at the beginning, even we tried to randomize and the characteristics of the kids between the two groups are quite similar, but we did not randomize their parents. And what we found is the quality of life of the parents in the control group who did not wear the orthosis start higher rate compared to the parents in the orthosis group. It started at 0.8 compared to the 0.7. And this difference continued over the study period. And what we found in general, it just remained like that. And it's not surprise at all if you're looking at the purple dots down below that there was a big proportion that the parents' quality of life in the orthosis was poorer than those without the orthosis. All right, let's move to the next slide, please. So now we know about the cause. We know about the quality of life, and now these two merge together to make it more complicated. And what we find, and this is often the result that we present and then talk to decision makers or clinicians or parents themselves to decide whether you should go for the orthosis or not. We're looking at two components simultaneously. One is the cause, another one is the quality of life. What you found there, for example, just let's have a look at the yellow dot point first. There are possibilities that we can find. 4 possibilities that we cannot conclude because it's all pretty much equally scattered across the 4 scenarios. What are those scenarios? The first one, the orthosis either improve quality of life of those who wear them, and also, and it associates with you pay more. There is also another scenario that the orthosis can improve quality of life, and then they save costs. There are other 2 scenarios as well, when orthosis doesn't at all improve the quality of life, but you save costs. And the last scenario is the orthosis did not improve quality of life, but then you need to pay more, which is the least desirable one. Anyway, same story happened when we're looking at the parents' quality of life and also the cost as well. But the chance will be more that the quality of life of the parents in the orthosis group are poorer than the control group. So with these 4 possibilities that we can see, we can't really conclude if the orthosis can provide the economic benefits in terms of saving costs and or improve the quality of life of both children and also their parents. Over to you, Christine.
Thanks, Oksana. So I guess just a couple of things to wrap up. So I guess the messaging from this study is that it's possible that there could be incremental benefit. And by that, I mean gradual increase in range of movement at 6 and 12 months from wearing an orthosis from the one that we designed. The orthosis that we evaluated could be tailored to individual children, but was different from a resting hand splint. So it's important to note that the style of this orthosis is specific to this study, so it wouldn't necessarily be compared to other orthoses that have been studied in the literature. We would recommend strongly that anyone who is provided with an orthosis, they need to be routinely followed up to check for any benefit. and that there are common side effects. So we really need to make sure that when discussions are happening with families and young people about whether or not an orthosis would be prescribed, that actually the side effects, even though they're relatively short-lived, need to be discussed and also managed. And then there's the issue of actually quality of life and what that impact might be, both for parents and for young people, and that conversation needs to be had as well. So we would say that we cannot clearly recommend that therapists should or should not give a wrist hand orthosis, despite that being our big aim for young people aged 5 to 15 years, because we didn't study enough children for long enough. So our findings suggest that there could be some benefits, but we do need more information to really conclude firmly. And if you are going to have one, you need to talk carefully with your therapist about what the potential benefits and costs might be for using this intervention. Just very quickly, want to tell you that we are continuing on with what we call our sister or partner study, which is the infant wrist hand orthosis study. So this study that we've just told you the answer, or what we learned about for the 5 to 15-year-olds, we had another study going at the same time for those aged under 5. And that study was able to get some more funding, and we have been able to recruit all of the children, our target recruitment, which was smaller because of the nature of the study. So we needed 94 families, we have 98, and we have 31 who have now finished all 3 years, and we aim to get to at least 65 by the end of the 3 years. So we're on track to learn about the same issues in the younger group. I'll tell you about that later. We really do want to thank everybody who's taken part in this study. It's been a massive, mammoth marathon effort, and it's still not finished, and we really appreciate people staying with us through that. We have used up all but the last minute of our time, knowing that we started a couple of minutes late as well, but are very willing to take questions and or receive emails to take questions outside of the session.